Good evening and welcome to the session of Learn from the Experts Step by Step. We have with us today three very good speakers and our expert panelists. So I'll just name them. We have with us Dr. B.P. Pandey, then we have Dr. Shomukanti Datto and Dr. Arindam Mitro. They'll be giving us some case presentations, and our expert panelist is Dr. Shubhanand Rai. So let me introduce Dr. Pandey, who needs no introduction actually because he's so well known. Just to give a brief profile, he's been practicing as an interventional cardiologist and is a colleague of mine and different cath labs around Kolkata for the last 18 years, mainly angioplasty, stenting, balloon mitral valvoplasty and pacemaker implantation. He's also highly experienced in the entire range of non-invasive cardiac tests. And Dr. Pandey did his DM cardiology from GB Pant Hospital, New Delhi. He's also served as a faculty at CSI and IAE annual conferences and has published several papers in various journals. So we just mentioned about the experience he has, and he's also a very, very good teacher, and he's doing a wonderful job at the Narayana Health West Bank at Howrah. So let us hear from Dr. Bijay Pandey. Over to you, Dr. Pandey.
Yeah, thank you, Dr. Vinayak Dev. So I'm going to present a case. Go to the next slide, please. This is a 66-year-old gentleman who had NSTEMI TROPI positive. It was actually 2 months back. And he was treated in the periphery, and he came to us with a history of unstable angina. In the meantime, he was being treated with the aspirin, clopidogrel, and beta blockade. And for hypertension, he was well controlled on 40 milligram of telmisartan, and his diabetes was well controlled on a 2-drug combination of empagliflozin as well as metformin. So on the review of his papers, his ejection fraction was around 50%, and there was some hypokinesia of the basal and mid-inferior wall. And the angiogram, we did it here, and we will show you. So this is the right coronary artery shoot. Here you can see that RCA is totally occluded after the RV branch. And on the next panel, you can see the left descending. Just run the previous one. Yeah, just previous. Yeah, previous. I'll ask you to go forward then only. Yeah. So this is the LAD view. Here you can see that the mid LAD has got around 70 to 75% stenosis. But what is more important, we'll see there is some retrograde filling of the right coronary artery as well. So basically, he has a 2-vessel disease. Circumflex was normal, and he was taken up for angioplasty. And we do not find much calcification. So LAD was pretty straightforward. The problem was with the RCA. And as a few months have passed by, so we had a suspicion that it's chronically occluded now. And we went ahead with our protocol of how to tackle CTO. So basically, dual injection. So one is, you can see, go to the next slide now. So we actually punctured the right radial for taking a shoot from left coronary artery, and we engaged our 7 French JR3 guiding catheter from the femoral axis. So there was a good collateral, but since the history was only 3 months old, I thought, why not try it without taking a contralateral help. So I took a BMW wire on a micro catheter and went up to the stump, and then exchanged it straight away with the Gaia 1. And to my surprise, without much effort, Gaia wire actually slipped in. Go to the next one. So this was basically with the support of 1 millimeter balloon, because initially with the support of the fine cross catheter, wire was not progressing. So ultimately I took 1 millimeter balloon to take a further backup support, and the wire actually slipped in. So then it was a straightforward. After a pre-dilatation with 1 millimeter, then 1.5. This you are seeing with 1.5 into 10 millimeter balloon. Go to the next one. So what we thought could be a very difficult case, considering it was actually very easy case. And after the dilatation with another 2 millimeter and 3 millimeter balloon, ultimately this is a 3 into 48 millimeter drug-eluting stent, and which was deployed and further post-dilated. Go to the next one. The temporary pacing wire you can see is lying in the IVC. So in cases of a right coronary PCI, that's the usual practice to keep the temporary wire in the IVC if you have taken a femoral access. And if we go from the radial access, then usually we do not put a temporary as a backup. We try to pace with the coronary wire if the need arises. So this result you can see with the post dilatation, we have a good result, and I did not do any imaging in this particular case. So go to the next one. So then this LED was tackled, and which was also a very easy cases. And after the pre-dilatation, we gave him a 3 millimeter stent. Go to the next one. The diagonal and LED was both wired just to preserve the diagonal branch because the bifurcation. Then we had pre-dilatation of the 2.5 millimeter balloon. And this is the result after. And then this was the 3 millimeter into 28 millimeter stent, which was implanted into the LED at a nominal pressure. And it was further post-dilated. Go to the next one. So this is the post-dilatation after the stent implantation. Next. And we did a pot just above the diagonal with the 3.5 into 8 millimeter for optimization. Here you can see that balloon marker should not cross the diagonal branch. So that is what we call the optimal pot. So when you are tackling a case of bifurcation, the length of the stent proximal to the branch should be of at least 8 millimeters so that you can do a proximal optimization, because we have a balloon diameter only at 8 millimeter. That is the smallest one. So if your stent is much less, then you cannot really do a pot. So go to the next one. So after looking with the pot, you can see the diagonal is well preserved, and we have got a decent result in the LED. The purpose of showing this vessel, this PTCA, is that what we consider is a CTO was actually acute occlusion, because by definition it is although the 3 months, but the going was so easy that in fact I could not anticipate I'll have such an easy job at hand. And that's it. So the planning is important, because in angioplasty, your 3/4 of the job is done if you study your CD well, plan ahead what are the steps we are going to follow, what is the backup plan if the wire escalation fails, what the wire. So things must be at hand. If there is a need for imaging, particularly if cost is not a constraint, that should also be in the armamentarium of at least the CTO angioplasty, not the standard, not non-left main angioplasty. Normally, we do not do imaging. So imaging is usually a must for left main, and in most of the cases of CTO, particularly when the going is tough, we want to visualize, are we in the true lumen or the false lumen? The imaging comes to our rescue. So this is the short presentation. Go to the, is there any other slide? I think this was the last one. So we can just, yeah. So this was, is there any question, queries?
Do we have our next presenter, or should we discuss the case? Subhabrata?
We can take the next presenter. We can discuss all cases together.
Together, okay. Dr. Datta, is he around? Has he come? Shubhananda has joined.
Yeah, by that time you can take Dr. Arindam Mitra's presentation. Dr. Datta is joined.
Okay. Dr. Shubhananda has joined. Shubhananda, welcome to the
Yeah. I'm
seminar.
sorry, I'm a bit late. I missed the presentation of Vijay.
It was a
So-
case of CTO, Shubhananda. It was thought to be a CTO, but then it was actually acute occlusion, which Dr. Pandey will again talk when we are discussing the case. And he had a LAD lesion, which was also stented with a wire in the diagonal. So, which we thought was a CTO, actually turned out to be probably a subacute occlusion. But the duration was about 3 months. So we'll discuss the case after Dr. Arindam Mitra. He will discuss a case. So about Dr. Mitra, has he joined the program?
Yes, sir.
Oh, Dr. Mitra, hello.
Yes,
So, Dr. Mitra, just share your slides.
yes, sir.
In the meanwhile, while you're sharing the slides, we have with our expert panel Dr. Shubhanand Rai. As we all know, he doesn't need much introduction because he's so well known as a renowned interventional cardiologist in Eastern India with more than 25 years of experience. Dr. Ray is a specialist in complex interventions, including left main stenting, rotablator, IVUS, OCT, FFR, bifurcation stenting, TAVI, and other lesions. He's also well versed in peripheral carotid and renal angioplasty, has numerous publications in national and international journals, and also involved in many path-breaking clinical trials as PI. Which is not mentioned here is actually the technique which he has in the bifurcation stenting, which has been very well accepted globally. And he's the pioneer of that technique, which he'll probably talk to us a little later. So welcome Dr. Shubhanand Rai to the show. And
Thank you, Vinayak, for your kind words. So we can.
Let us just see Dr. Arindam Mitra. He's just presenting the case of a bifurcation stenting. And Dr. Mitra, he's third year PDT cardiology at Medical College, Kolkata. And we're looking forward to your presentation, Dr. Mitra. Please.
Thank you, sir. Good evening, my teachers and respected sir. Today I'm going to present a case of bifurcation stenting. We have this 67-year-old male from Midnapur presented to us with CCS class 2 angina for last 1 year, which has increased since last 1 month. He is hypertensive. He has got controlled dyslipidemia, current smoker, but non-diabetic. We unfortunately couldn't procure the ECG. His echo was normal with ejection fraction of 62%. He is currently on aspirin, clopidogrel, atorvastatin, metoprolol, amlodipine, telmisartan, and anti-anginas like GT and ranolazine. He underwent angiography elsewhere, which showed distal LMCA lesion, proximal LAD lesion, a mid LAD 90% lesion with LCX proximal 60% lesion with Medina 111 classification, and the syntax score came out to be 39. So he was offered the choice of the CABG versus PTCA, but he opted for PTCA. So our plan was to go for left main bifurcation stenting, image guided stenting using nanocrush technique. So this was, we used EBU 3.5 7 French catheter, femoral access. This is the angio shot showing the distal LM bifurcation lesion as well as a significant lesion in mid LAD. So we first decided to stent the mid LAD. We were both the the main LED and the second diagonal. So we used a 2.5 by 38 millimeter and deployed Rein's prime stent and deployed in from mid to distal LED at 14 atmospheres. After post dilatation, this was the result. Now we decided to take an IVAS run from LAD to LMCA as well as from LCX to LMCA. Unfortunately, I don't have the IVAS images. Now we had both the LM to LAD as well as the LCX. After vessel preparation, we took the LMCA stent and as well as placed NC balloon in the main vessel in the LAD, and we inflated the NC balloon at nominal pressure and pulled the stent up to the balloon, and then we deployed the stent in the side branch, that is the LCX, that is 2.75 by 28 millimeter at nominal pressure. Then we pulled up to the pulled the stent balloon in the we pulled the stent balloon up to the from the side branch and inflated at nominal pressure so as to open the ostium of the side branch. And then we go for the first kissing balloon inflation. Then we took the stent in the main branch, that is Rein's prime 3.5 by 33 millimeter, and deployed it at nominal pressure. And we do go for the pot by 4 by 8 NC balloon at 16 atmospheres. Then after that, after the pot, earlier we removed the stent delivery system from the side branch. Then and also the balloon from the main branch. Then we again recrossed the LCX, and we did the final kissing inflation. And again, we have gone for the repot with 4 by 8 NC balloon at 18 to 12 atmospheres. And these are the final angiographic results. So my take-home messages are: this is an ideal cross segment, should have a limited crush length of cross segment is the main branch. Nano crush is an optimum elective double stent technique for bifurcation lesions, which is safe, can be performed easily, does not require any complex wiring and ballooning. Also compatible with 6 French catheter, though we chose a 7 French catheter for our case. It has overcome the limitation of DK crush technique, like excessive protrusion of the side branch into the main branch, while at the same time covering the ostium of the side branch also completely. Due to relatively lower metal load at the carina compared to the classic crushing technique, recrossing is also relatively easy. So thank you.
Thank you, Dr. Mitra. I think I hand over the forum to Dr. Shubhan Andre to ask his questions to Dr. Mitra, and then we'll go over to the case presented by Dr. Vijay Pandey. So over to you, Dr. Ray.
I must congratulate this young man for his excellent work. I mean, the result is excellent. And moreover, there are few advices about, because nano crush is very, very procedure dependent. Every step is very important in this case. Otherwise, there will be a lot of troubles. First of all, you did not mention what is the size of balloon you took for the main LMCA to LAD while you are pulling the side branch stent, that is LCX stent, inside. Because this is utmost important. If the LED proximal diameter is around 3.5, you need to take
Or
a stent,
2.5.
Nikon balloon, which will be quarter size smaller. That is, you should take a 3 millimeter balloon at least, not a 3.5 balloon, a 3 millimeter balloon, so that a part of your LCX stent goes inside the main branch. This is the main thing. Number two, if when you when you are after deployment of the LCX stent, you are pulling the stent balloon inside the LMCA, you need to go a very high, this thing, very high pressure, at least 18-20, because you need to open the ostium. At nominal pressure, the ostium will never open. This is number two. Number three, there will be a third step. Now you have to sequentially dilate by the NC balloon, which is placed in the LMCA to LED in a very high pressure, 18-20, so that the excess part of the stent is flattened or crushed. Then you do a fast case at nominal pressure. This is the 4 steps, which is very, very important. Otherwise, you'll be in deep trouble. So these are the few things I thought that either you forgot to mention, or this you should remember every time, so that your everything will be nice and you will have no problem in doing a complex bifurcation.
Subhananda, when you pull the circ stent, whether your left main to LED balloon remains deflated, or
no, it is inflated. It is inflated at the normal pressure.
At the
you
nominal
take
pressure.
One side, nominal pressure. You take a balloon which is quarter size smaller from the distal proximal LED, and you inflate it at a nominal pressure. Then you pull the stent to the inflated balloon. So a little part of the balloon, that is at least 1 to 2 millimeter, will be inside the left main stent.
And after crushing with the LED balloon, we have to recross.
No, we are already, you are within the stent. That is the difference between decay crush. Decay crush, you just deploy the stent in the LCX, in the side branch. Then you remove everything. Then you crush. Then you recross. Then you go for a first case. But here in nano crush, you are deploying the stent in the side branch, pulling the stent balloon up, inflated it, and flaring the excess part of the stent, and then crushing with the left main balloon, so that
when we are crushing with the LED balloon, we are taking the stent balloon out, keeping the wire in.
No, right? It is inside. No, it is deflated. It is out. It is inside. It is inside but deflated. Now you crush the balloon, you are never losing the wire balloon. So it becomes easy,
So what is the purpose of keeping the balloon inside?
Because you have to do the second case, first case. So you are having the balloon there where you have just inflated the
audio is not
the side branch, and you have kept hello.
Yeah, yes.
Hello.
In between audio.
Yeah, it is
it
okay
was
now.
Not, it was not clear.
No. Point is, when you are flaring the stent, side branch stent, you are keeping the balloon inside.
Right.
So next step is you are crushing the excess part of the side branch stent, which is in the main branch, and in presence of the deflated balloon there, and there after that you do the fast case. So the stent in the side branch, excess part of the stent in the main branch from the side branch is actually flattened. So when I presented this case to European Bifurcation Club, Dr. Lugert said, he was the president there. He said that actually we should call it is not a crush. It is a circumferential shortening of the size branch. So that is the reason why we do not miss the ostium, number one. And number two, there is always a circular opening of the side branch.
So just one more query. Suppose one strut is projecting into the left main, and
Mhm.
we are keeping the stent balloon inside the left main to LCX,
Okay.
and we are crushing with the LED balloon. So what we are actually doing, we are crushing only the one part of the stent, circumflex stent, and not the other
Exactly.
side of the stent.
Now, if you draw a picture, you will see that when you inflated the circumference balloon, and the part of it is in the left main and part of it in the circumflex, then the posterior part, if you consider anterior and posterior of the, and in a 2D view, the posterior part is actually in contact of the side branch balloon, and it is flattened.
Okay.
The extra part, the anterior part, is crushed by the
LED balloon.
main LED balloon. And when you inflate both the balloons as a kissing, it has a symmetry. The anterior part is suppressed, posterior part is flattened.
Okay. Okay.
Okay, Dr. Ray, in this particular technique, do you need to have any particular angle, or is there any contraindication of any angle
No.
between the two bifurcation? Or can it be done with any angle?
Any angle. Actually, in any angle. We have tried in any angle. First, our paper, which was published in Asian Heart, there we published data on right angle or obtuse angle bifurcation. And with the next paper, which we published in Italian Journal of Cardiology, and that is Minerva, there we published our narrow angle. So both the angles, it can be equally effective.
So this is a technique where actually any angle is okay with you. I mean,
Any
this
angle
is
is
one of
okay.
the techniques. Yeah.
One of the techniques. And the easiest technique possible, I believe.
So any shortcomings of this technique you feel in the bifurcation?
Yes, there are two shortcomings. Very important question and very important things to remember. If the left main is very short, do not try cross stenting, because you won't have a proximal handle to cross. There, the two stents will open like two barrels. That is the problem. And this is one shortcoming. In very short left main, we do not try it. And if the arteries are very small, like 2.5 arteries, main branch and side branch, I do not try this thing.
Okay.
Nano crush, yes.
Nano crush. And definitely the steps are lesser compared to the DK crush.
Yes, it is very easy. Once you do it, and you know that it is very easy. And the crossing to the side branch is as because you see these young guys, they can cross. But you remember, both Bijoy, you and me, we are old people now. We know that how it is difficult if you do a mini crush. Sometimes it is so difficult. Even a veteran worker like Dr. Gambhir could not cross. I have seen Antonio Colombo could not cross.
Yeah, that's true.
So this was a problem of mini crush. And now after nano crush, I see every patient, young man, when they're starting easily crossing. No problem, absolutely.
So I think that the pullback with the balloon inflated into the main artery is the most important area. Because there lies the entire thing.
Points. Yeah. There are two very important things. You are not losing the wear and balloon at any time. Always it is in your hands. So you can control, first of all. And number two, the crossing is so easy. These two are the very important, this thing of a nano crush.
It will be a difficult thing if actually you pull it back too much also, isn't it? I mean, the nano crush, you are not missing the ostium, at the same time you are not also pulling it too much inside the left main.
Yes. Yeah.
So can I ask you that whether this technique is also equally good for, say, a LED D1 and a Circ OM compared to a LED Circ?
I think the easiest is LED D1. Easiest. If somebody starts I mean, he plans to start nano crush. It is best to do on LADD1 because it is the easiest. But
Yeah.
circumflex is always a very difficult artery. You know, with the Peter, everybody knows, like all of us who are practicing intervention for considerable time, we know that the most difficult branch is circumflex because it is a hidden angle. You do not know which angle you have to put your side branch. So it is difficult. I think the best is LADD1. After that, once you get experience, you will do anything.
Dr. Solomon, any questions from you?
Hello.
Dr. Solomon, doctor, you are muted. Can you unmute yourself, Dr. Datta? Yeah.
Yes, sir. Yes, sir. Am I audible?
Any suggestion?
Your voice is not clear, sir. Am I audible?
Yeah, you are audible now.
Yes. Sir.
Any questions or any suggestions from your side regarding the bifurcation stenting?
Yeah, I generally do according to the angle. What sir said, according the Dr. Suvarna Roy said rightly that my preferred choice is obviously the nano crush or decay crush. But obviously, if the angle is wide or if the stent is not crossing, then generally I do prefer with the provisional stenting strategy. And if I fail, definitely T is coming. T and TAP is coming as a second option for me. But otherwise, in angle. If the angle is less than 70 degree, definitely mini crush or decay crush or in LADD1 or L6M bifurcation, if the arteries are same, then only I do go for a culotte or mini culotte. Otherwise, mini crush is the perfect strategy for me.
The thing is that there is no problem in doing any of the crushes, but
yes,
remember,
sir, definitely.
The problem is in mini crush, it is sometimes very difficult to recross.
Yes,
we have
definitely.
seen that.
We must be prepared with the new hardwares and small size balloon
also,
to open the struts. Yes, sir.
Yeah, that is difficult, and so
definitely. Always difficult.
And
always
also,
difficult.
Also, and I am practicing bifurcation since 2000, and I can tell you after 20 years, maybe 23 years now, I can tell you one thing: accepting the left main or accepting in a very large side branch and main branch, I do not find any justification on putting two stents in the bifurcation. The best technique so far is provisional. Because if you look at the long term and if you look at the safety profile, the best option is provisional. Why? Because if there is a restenosis in two stents, what you do? It is very, very difficult to control. But if you have a restenosis after provisional stenting, one stent, it is much easier to handle. So to me now, I do two stent bifurcation only in exceptional cases nowadays. I prefer provisional. It is much safer and much safer, and you have to think over the patient safety first and the long-term data, not the procedure. You can do a lot of things, but ultimately it is a patient who matters.
I think, Dr. Ray, actually, when we all attend meetings and conferences, it seems like 90% of the cases are done with bifurcation stenting. But the truth is, only 70% cases are 30% cases are probably bifurcation, and 70 is provisional. But when you're presenting cases and you're in meetings, it seems like everybody is doing 100% or 90% bifurcation, which is actually not the true world case.
I have seen the ugly face of it. If there is a restenosis after two stents, I know what can happen.
Yes, sir. Recently I have faced such situation, sir. I had done a mini crush of LCX-OM, and the LCX origin was severely calcified, as you rightly said, and the angulation was extremely bad. So there was ISR in both LCX as well as the WEM. The WEM was totally occluded, and believe me, even after several trials, I could not cross the WEM again. I did only the DEB to the LCX. So this was a 1.5 year follow-up patient, 54 years gentleman, non-diabetic patient. He was taking DAPT properly, and in spite of that, the WEM stent could not be opened up. I tried a lot. I could not recross the total stent because it was totally occluded just after the WEM started. So I just did one DEB to the LCX only. So this was I could not show you the results, but this happens. This is quite common findings in bifurcation stenting, sir, as you rightly said.
I
And
think,
also-
Dr. Ray, that, when we started our angioplasty careers, the hardware was so difficult those days that the complications and the instant stenosis were actually related to the hardware problems. But in today, in 2023, the hardware is not an issue anymore. I think it's the judgmental calls and the skills, and more than skills, I think it's the judgment calls which creates these problems. So I think people who have been doing it for at least 2 decades, we have all transited and understood the theories. But I think the people who are starting their careers, I think for them, the hardware issue is already out of the window. They don't have to worry about the hardware issue at all. It is only the judgmental calls. I think, that is the most important, as Dr. Ray just mentioned. It's only the patient's benefit in mind which is to be kept. And also that when people will come with a restenosis, you have to understand if it was 2 stents, the difficulty you will face in tackling that case. As Dr. Datta just mentioned, that DEB was the only choice in that particular case. So I think we'll move on to Dr. Vijay Pandey's case. Dr. Ray, that Dr. Pandey's case was one of RCA total occlusion, which was thought to be chronic total occlusion, giving the duration of the occlusion. But I think he crossed with, I think I'll ask Dr. Pandey to just retell the case, just verbally. Dr. Pandey? You are just unmute yourself.
Yeah.
Yeah.
So it was a three-month-old NSTEMI actually came after 3 months with unstable angina. RCA was total and LAD 75-80% LAD diagonal bifurcation. So went ahead with the contralateral puncture, but actually with the support of microcatheter wire, Gaia 1 went easily. BMW could not cross with the support of a microcatheter, but Gaia 1 just slipped in. So it was easy, and LAD diagonal, as we were discussing, it was a provisional stenting, and there was no pinching of a diagonal branch. So it is all in the planning actually. So as I said, 2/3 of the job is done. Once you see your film, assess the patient before putting them on the table, decide about what all hardwares you are going, how you are going to escalate the wire. There cannot be excuse that I wanted this but could not have this. So it is all about planning in angioplasty and nothing else, because
Absolutely.
nowadays hardwares are there. If you know your plan A, plan B, plan C, most of the time you will be successful.
And
Dr. Ray,
also,
about this Dr. Pandey's case, just one question I wanted to ask you, that when you're talking about the chronic total occlusion, is it the difficulty you faced actually in crossing and performing the TCR, or is it based on the chronicity in terms of months, or is there any criteria how will you tell that this is a chronic total occlusion?
yes, but I mean, I go by JCTO score. The first thing is proximal, cap ambiguity. If the proximal cap is having a nipple or
Kishore, just you can project the RCA first shoot.
Okay. Hello.
Yeah, continue, Shovananda, continue.
So JCTO score, I see about if the proximal cap is not ambiguous, that is not, it is not a blunt CTO, we call. Then, hello?
Yeah, you can look at the picture, RCA.
Kishore, do the full screen.
Yeah, beautiful nipple. The RCA has a beautiful nipple. So
with the side branch.
Yeah, side branch, but still there is a beautiful nipple, first of all. And this nipple show, if I see this nipple, I know that my success rate is more than 50%. Now, next is whether there is a bend. If there is no bend, if it is a straight segment, more or less, if I anticipate that there is a straight segment maybe, then my job is done in 80% of the cases. And number 3, If it is a native lesion, it's not a retry lesion. Again, my success rate is around 90%. And if it is not a calcified lesion, my success rate is 95%. So basically, JCTO score, through all the points, it is mentioned in JCTO score. And through the score, we know that if the score is 1 or 2 or 0, we know that the success rate is almost like a normal angioplasty. So in Bijoy's case, it has got a beautiful nipple, and the length is not very long, I believe. So Bijoy, veteran operator like Bijoy, he could perceive that his job would be very easy. That's why he took a microcatheter and a Gaia wire and Gaia 1 wire. And Gaia 1 has got a beautiful property of slipping into the microcatheter, and it has got an easy deflectibility, so that if there is a very hard lesion in between, it can deflect its tip and go inside. So that is the cause of his success. He could judge the lesion, that it could be easily passed, took the hardwares, chose his hardwares nicely, and it is the cause of his success. So it is a teaching case. And for the younger generation and younger people, interventional cardiologists who are listening, select your case nicely and you will have success. If you take a case of blunt CTO, long CTO, calcified, it can be a very complex disease, and your success rate will be very less.
So Dr. Ray, how frequently would you do a CT angiogram to decide on the length of the CTO and calcification in the CTO or not? How frequently would you do it?
To be very frank, I do not do it.
You don't do it at all.
It is no. I know that there are, a lot of theories about that, but still, we believe in angiography, and usually, which I do, that is I do a contralateral shot and two shots together, antegrade and contralateral both, and so that you know what exactly the length, you can have an idea.
But do you think that by doing your CT angiogram beforehand, you would have a better idea how to prepare if your lab is not very equipped with the CTO hardware? If you do a CT angio before, at least you will prepare yourself better. Not all labs actually have the facilities.
Yeah,
for CTOs.
In that case, you need a very good CTO, a very good CT, radiographer.
Yeah. So can I add, sir, one thing? If a CT angio machine is associated with a CT FFR, and you have a proper data regarding the calcium load of the CTO segment, then definitely you must be prepared with your devices. Suppose the proximal cap is a thicker and the Hounsfield unit is around 1000 or so high. So you may be prepared with that thing, and we may plan according to the proximal or distal cap according to the CT angio. And if the FFR is there, and if we can see what you have said rightly, that if we can see the retrograde part or the distal part of the CTO is filling and the FFR is almost good, then we may decide the length of the CTO as well. So definitely CT angio with the CT FFR definitely guides us and helps us in preparing the lessons. And specifically in such cases of Dr. Pandey, if the guide wire is, if the wire is going to the another branch, definitely a crusade or any other microcatheter or with other devices, orbital atherectomy or any other devices may help us in very difficult cases. But definitely CT angio helps us in preparation of any CTO cases. Definitely we do not do regularly, but it helps. Yes, sir.
Yeah.
Just a minute.
I have another viewpoint.
I would tell you one thing.
Yes,
tell
sir.
you one thing.
Yes, sir.
Intervention is a matter of practice.
Sure,
it's
sir.
not by theory. It's not a theory. The problem is you have never practiced it. I practice sometimes, so I do not depend on it. See, for CT angio, you need a very good radiographer to stamp on it. So it is not easy. From CT angio, to know that load of calcium, it is not very easy. It's very difficult.
The reports are most of the time are not authentic also, sir.
Just a minute.
Yes.
Let me finish. FFR does not help. FFR will help in intermediate lesions. But in CTO, what FFR will do? FFR, you know that there is a complete block. So FFR will not help you here. the two things which will help you, that is the load of calcium and the length of the disease. Now, from CT angio to know what will be the length and exact load of calcium, and whether this calcium is within the lumen or outside the lumen, it's difficult. It's not easy. When there is a calcium, CT cannot see anything. Have you ever gone to your lab to see a CT? If there is a huge calcification, if the calcium score is more than 1000, you cannot see anything, any lumen.
Yes.
Actually,
These people,
CT angio is a
radiographers,
contraindication
they
if
will
you have
say
so much of
that, yes,
calcium. It will not give you
Yeah.
anything at all.
if there is much of calcium, we cannot interpret. You go for a normal angio.
Yeah, you have to go for a conventional angio.
Contralateral
Dr.
short.
Pandey, you
that's
wanted
it.
to say
Yes.
something.
Yeah, I was saying that CT is helpful only if there is two things. Your lab has to be co-registered with CT scan, because we want to know if there is an angulated lesion. If my CT angio can be projected onto my screen, then only wiring becomes helpful. Otherwise, with the easy availability of intravascular ultrasound, it has lost its value nowadays.
Okay, another question, Dr. Ray. What about bridging collaterals in a CTO case? I mean, do you think it's a difficult scenario, or can you have any comments on that?
The and collaterals, they are initially when we started doing intervention, collaterals were very, very important at that time, because the wires were not that advanced. Nowadays, in all the CTO score, they do not include the collaterals. So the importance of collaterals has come down. Even the JCTO score or progress score, they do not include the collaterals.
No, I'm talking about bridging collaterals between the two segments.
Yes, bridging collaterals.
Yeah,
The collaterals are important. That is for retrograde. And only these types of collaterals are important, whether it is a type 1, type 2, type 3 collaterals. These are important for retrograde. This is not for, antegrade crossing. They do not help.
The only thing which I find is if you have a bridging collateral, if softer wire if goes into that channel, I keep it that as a landmark for taking as the parallel wire. That is the only help.
That's it. Yeah, that's it.
Do you have any choice of having microcatheter in bridging collaterals? Any kind of microcatheter choice?
No, basically, some people think that a double lumen microcatheter will be helpful. But in my lab, I am not very concerned about the double lumen or so. If in presence of bridging collaterals, if I see that there is a plant CTO, there is bridging collaterals, after some time I go with antegrade wiring first, then I go to retrograde. As simple as that.
I think we'll move on to our next case. Our presenter is going to be Dr. Soumyakanti Datta. Just to introduce him, Dr. Datta. Dr. Datta is a cardiologist at IPVM and SSKM Hospital, and have a specialty in cardiology and has worked for SSKM Hospital and IPGMR. He's also currently the head of the Department of Cardiology in BP Poddar Hospital, Kolkata. He's going to talk to us about calcification and the treatment of calcified LAD with a special technique, which is IVL now. Over to you, Dr. Datta.
Yes, sir. So it was a case of elderly 79 years old male elderly patient presenting with NSTEMI at the mid of the night, excruciating retrosternal chest pain. He was non-diabetic but hypertensive. His blood pressure was around 180/90 and the TROP-T was positive. So I took him to the table, and the most important thing what I would show here is the lesion. So he was having chest pain for at least 3 months off and on, but the chest pain increased for 1 day, and this was the lesion. You can see that starting from the LMCA to the proximal LAD, it was severely calcified. It was severely calcified, and the mid LAD there was an 80% lesion there too. So this was a tough decision after the spider view, whether I should put a stent from the LAD ostium or I should include the LMCA2, because it was involving almost the ramus ostium as well, and the LCX ostium was nearly close to that. RCA was near about normal. So the plan, what I did, I wired both the LAD as well as LCX, and his ejection fraction was around 50 to 55%. As you can see, the tram track calcification starting from the LMCA to the LAD as well as the mid LAD. So luckily that day I did not have rota at that time in my lab. So luckily that day Tisho was there nearby, and he helped me with IVL. So what I did, I pre-dilated, very difficult to cross with a smaller size balloon. I started with the 1.5, followed by 2, followed by 2.5 and 7.5. So I dilated almost all the LADs as well as the proximal LAD as well as to some extent LM. But I had difficulties that I may face dissection. Luckily, there was no such dissections was noted. So what I did, the same size pre-dilatation, because the IVL balloon was 3 into 12, so the same size pre-dilatation had to be done. But so I started with 2.5 NC balloon, followed by 2.75 and 3 NC balloon for the proper bed preparation. But in spite of that, before the IVL, the LMCA to LAD calcification, I could not broke that calcification. So I started doing IVL, gradually releasing the pulses from the mid LAD, 20 pulses to the proximal and the LMCA, rest of the 60 pulses I provided there. So as you can see, this is an IVL balloon. I started from the distal to the proximal to the LMCA even. Previously I had a bad effect that in such cases of eccentric calcification, the IVL, when I inflated from 4 or 4 to 5, it ruptured because of the calcium spicule it had. I had a bad time that then I succeeded again in another case with a rotatripsy, but this case was a typical because it involves almost on the starting from the LMCA to LAD. As you can see, the post IVL shot, it was the calcium was totally almost circumferentially it was cleared, and we can pass. We can have a good bed preparation, and there was no dissection at all. And the thing is that the ramus as well as the LCX ostium was too clear. There was no dissection. So I am showing you again the post IVL. Almost the bed was prepared so that I can deliver my stents. So I started doing stents from the mid LAD. It was a long stent with a 3 into 32, followed by the overlapping stents. I delivered from the mid LAD to the LM, because I had to involve the LM as well, because it was involving the distal LM too. But as you can see, there was to some extent a bit calcification was there in the ramus ostium as well. So after the IVL, after the first stent, this was the lesion, and I started doing the post dilatation with the 3 followed by 3.5 and NC of the proximal LAD with a 3.5 and pot of the LM and LM to LAD with a 4 into 10 balloon. This was the pot, you can see. And this IVL, after the pot, there was a slight pinching of the ramus ostium. So I recrossed with a run through only. I recrossed the ramus ostium and I dilated again the ramus ostium, but I left it again with a repot. So there was no such deviation of the ostium. Then this was the final result you can see. So this was a simple case, but the thing is that when we are having trifurcations at a closer angle, rather than preparing with a rota or having orbital atherectomy, this IVL gives us a much more brilliant result of preparing the bed. So what was this case I want to discuss with Dr. Subhanan Rai, Dr. Pandey, is that what is your choice regarding the calcium issues of Rota? Rota Pro is coming now, IVL is in our hand, and now the orbital atherectomy is coming. So what is your decision regarding this case? What will be your choice, sir?
Dr. Ray?
I am doing Rota for more than 12 years.
Yes, sir. So your expertise in Rota, sir. That's what, sir.
So I know calcium very nicely.
Yes,
but
sir.
I also, that does not mean that I do not use orbital or IVL. I have done everything. So yes, I can tell you that there are two very important points which you ignored. First of all, your LMCA to LAD lesion was never calcified, first of all, because I have never seen a osteal LAD, calcified osteal LAD opening with 20 shocks. It is not possible. If it is a
distal LAD, I provided 20
I'm
shocks
coming to
and
that.
yes, sir.
You told me that the LMCA to LAD was 20 shocks and distal LAD 60 shocks.
No. Proximal
shocks.
LAD, sir. Proximal LAD 60 shocks with the LM also. Sir,
Then
here
it is you mentioned wrongly, I believe. So
Okay,
this is
sir.
number one. Number two is your IVL balloon for LMCA osteum, LAD osteum and LMCA disease should always be more than 3. It should be 3.5 because you put a 3.5 stent overlapping
Yes.
from the
Yes.
osteal LAD. So in a IVL balloon, if it is smaller than the original lumen of the artery, it will never open fully. So I think your calcium there was not very dense. Your calcium was probably dense in between, where peripherally probably. I don't know. I have not seen your case. But in a case, if you use IVL for a left main, you do not have other options left. You are doing it on intention. And there, you need to select your balloon nicely. It should be according to the lumen of the distal artery. So
Sure,
if you take a smaller balloon, it will never act.
Yeah,
This is the rule.
That is mandatory. That is a rule that we should prepare the before IVL also with the same size balloon and preferably with the IVAS. If there is 3.5, the balloon
No,
must be
not
3.5.
IVAS.
Yeah.
First IVAS is there is also a problem. IVAS cannot. IVAS is done nowadays. Now the data are coming that what would be the IVAS lumen or IVAS measurement after in IVL. But when IVL came first, then it was distal lumen angiographically. Now people are saying that if you can do an IVAS and put an IVAS and see the external elastic lamina to lamina, that would be the right side of the IVL. But it just came later. Now, if you do not have an IVAS, you need to do from the distal lumen.
Yes,
This is the and number two is in a patient where there is a osteal LMCA to osteal LAD deletion. Mostly it is osteal LAD deletion. So in that case, it is better to use a rota first because not always your balloon will crack the calcium to allow your IVL balloon in, and there might be nasty dissection. So that can happen. So in that case, where there is a very severe calcification at the ostium of the LAD, there I think it is better to go with a rotational atherectomy or an orbital atherectomy and do the rest. And I can tell you, gradually, orbital atherectomy will be the route, will be the procedure of choice. Why? Because it is better always in a large vessel, in a short calcified segment, and it can manage the calcium so well. It can prepare the plaque so well. If you use a semi-compliant balloon at 6 atmosphere, it will open.
Yes, sir. It cuts both ups and downs, so it definitely helps.
So in orbital atherectomy, in the three devices, if it is a short calcified segment, if it is a large vessel, my choice is orbital atherectomy because it can cause calcium modification best, perhaps.
Dr. Ray, circumferential calcium is something good with the rota and the IVL. What about eccentric calcium or the calcific nodule?
Is a wonderful question, and I calcium nodule, nothing, because rota is dependent on rota wear bias. So if you can use your wear bias to the nodule, it will cause cracking of the calcium. Otherwise not. But again, IVL is doubtful whether it acts on nodule or not, because it best acts on circumferential. But because this orbital atherectomy moves in an elliptical way, it opens all the things. Perhaps the best option for nodule is orbital atherectomy.
Sir, if you go for a rota, will you keep another wire in the side branch or LCX or
No,
REMAS?
no,
or
never,
you will-
never, never, never,
Yes.
never, never.
No,
Because
no.
Definitely. no.
never, because the road that wire will cut.
Yes.
And also I tell you, if you do a rota to a branch, the other branch will be remaining intact. I have
Yes.
never seen a branch close after rotational arthrectomy.
Yes, sir.
Dr. Pandey, your experience with calcium.
Yeah, as I said, Rota is very cost effective. Unless the cost of IVL comes down, it's much cheaper, easier, and nowadays most of the lab have Rota in-house rather than IVL in-house. So there's a lot of advantages of getting the Rota done. The only problem I see around that people are not very meticulous with the positioning of the distal Rota wire. So we see a lot of complications in different meetings like perforation. So one has to be really careful, but with coming up now a softer wire, which you can wire even without a microcatheter, as Dr. Rai showed in our last meeting. So things are going to be much easier for Rota. Regarding orbital, I do not have my personal experience so far. So for me, it's a Rota all the way.
I think the learning curve in Rota is there, which is actually probably very little with the IVL. So that's why I think that is one of the IVL is taking precedence. But I think technically and scientifically, the rotablation is definitely a proper procedure for tackling calcium. So I think people should take that kind of the problem, actually learning the whole thing and be very good at rotablation. I think IVL probably is not something which is the answer to calcium, because I think it's a very niche indication you have got for IVL. It cannot be compared to a rotablation. That's my personal
Well,
view.
if it gets puncture, you are 2.5 lakhs down the drain.
Well, that issue I think depends on
So
how
always
robust you
save-
are in.
Always save it before you ultrasound it.
Yes. Okay, I think Dr. Arindam Mitra, he's very quiet. Do you have any opinions, Dr. Mitra, and then we can close the meeting?
Yeah, for Arindam, I had a question. Why do you routinely put temporary into the RV while doing left main plastic?
Yes, sir, it is our practice. Yes. Usually
That's a cause for concern. Actually, we see so many things with the temporary. And when do you remove the temporary after the procedure? On the table or later?
on the table, sir.
This is another thing. On a fully heparinized, if you have done a micro perforation, you will shortly see the tamponade. Everyone has seen it. So
Yeah.
if you are so unsure,
100%,
balloon tip
100%
temporary
on that.
pacemaker, balloon tip temporary pacemaker, I think is the safest thing. Or why not
Safest
just keep in the IVC? You are doing Rota, you can always pace RV. There's not a great thing for a cardiologist to put in case of emergency.
Okay.
And basically, I would suggest that if the circumflex is very large and dominant, then it is better to put a temporary pacemaker. Otherwise, for a left main, you do not require it. You can keep it in the.
I think
IVC.
what Dr. Pandey has just mentioned, the heparinized patients with tamponade, it is not very infrequent actually, because
Not
a
very
lot of people
infrequent. We
use,
have lost a lot of patients.
yeah, a lot of wires which are old wires and which are very stiff. And I think something, as you mentioned, that IVC placement of the wire is probably okay. And then if you need, you can always go in. It will take a few seconds only to do that.
Yeah.
And we are all surprised how little actually the pacing wire is used after the whole angioplasty is done. Yeah, okay. So I think we had a wonderful meeting, and I would like to thank Dr. Shubhanandre for giving his time. I think he's just out of the lab and still traveling. And thank you for joining, Dr. Ray. Dr. Vijay Pandey, as usual, has contributed very hugely to the meeting with his case and discussions. Dr. Somo, thank you very much for showing a wonderful case and some discussion points. And overall, Dr. Arindam Mitra, I think your case was also very good case for discussion. And I would like to thank Abbott for supporting this meeting. and wish all of you good night. So have a good evening. Thank you.
Thank you.